Hello and welcome to the live stream of CGTN online medical consultation and seminar on the treatment of the COVID-19 infection. I'm Tom Bo in Wuhan. China Global Television Network arranges the meeting and the platform to help medical professionals from around the world exchange their views and discuss on how to get a grip on COVID-19. And if you have any questions for doctors and COVID-19 experts, please leave them in our Facebook comment section below or use hashtag #MyOpinionOnCovid-19 to share your views. CGTN will take your questions to the professionals and discuss them in the live stream. And let me first introduce our participating professionals from Peking Union Medical College Hospital, which was founded in 1921 by the Rockefeller Foundation. It is a national center guiding the diagnosis and treatment of difficult and serious diseases appointed by the National Health Commission of China. We have with us today Professor Cao Wei, physician of infectious diseases of the hospital, and Dr. Fan Junping, pulmonologist from the hospital. And from the UK, we have with us today Professor Sean Griffith, who is chair of the Global Health Committee and associate non-executive member of the Board of Public Health England. And she was president of the UK Faculty of Public Health of the Royal College of Physicians, as well as the first co-chair of the UK Public Health Association. And from the US, we have Dr. Kate Tulenko, who serves as CEO of Covers Health, a global health workforce services company, which provides recruitment, staffing training, HR management, quality improvement, and advisory services. She is a globally recognized expert in health, workforce, and health system strengthening. Welcome you all. Thank you very much for your participation.
Thank you.
Yeah, let's start with the question and answer section. Anything you want to exchange and discuss on, we can start it from now.
Thank you. I think you probably know that the UK is facing an increasing number of cases, and we already have some social distancing measures in place, but we're talking more about moving to lockdown, and I wondered what your experience of lockdown really meant. How do you provide the basic services to people? And do you leave people, when they get sick, do they stay at home until they need to go to hospital, or do they get hospitalized earlier in the disease?
Yeah, thank you for the question. I'll give a brief introduction of the lockdown strategy in China. It actually started 2 days before the Spring Festival in China, which is actually the start of the holiday. So, which makes the lockdown of the city relatively not that difficult at that time. So lockdown means, for Wuhan, means that the people are forbidden or are restricted in going out or into the city. And citizens inside Wuhan City are required to stay home if they have no specific reasons for going out. And people are allowed to going out, including those medical workers who are working at the front line to treat patients. And also, we have a large group of volunteers by the government to help those stay at home to continue their life without going too much. For example, the volunteers will help to arrange the grocery stores, grocery things, or needed medication. If they need them, they can require the volunteers to send to them. And also, at the same time, a screening of all the citizens, nearly all parts of the city, has been started at that time to make sure everyone who could potentially be a suspected patient to be included in what we call the emergency setup medical center, to make sure that people will not are not spreading the disease in their families. Because as you know, most of the families stay in China, especially in big cities, are still living in apartments, which share a lot of public places, not like not like most families in Western countries. A lot of them, I assume, will live in houses which are relatively separated from each other. But the families in China, especially in big cities, apartments is a usual setting for almost all the families. So to get all the patients, get all those who can potentially be infected, and focus them together was an important measure to stop the spreading of the disease to their family members. So another important thing is that at the same time of the lockdown, we also recruited from all over the country medical workers from different parts of the nation to be sent to the city to help to fight with this battle, because the lockdown means that those medical workers remained in the city. There was a relatively shortage of the medical devices and the medical workers, and you want to make sure that all the resources left in the city will be sufficient for you to fight this battle, because all this battle will be settled in this city. So about 40,000, I think, medical workers have been sent to Hubei province from different provinces of China to help the medical workers, local medical workers, to fight against this battle.
Thank you. I think we would be interested to learn, as you say, living conditions are very different, which makes it quite different in terms of distribution of food to people in the community, because we have the disease in rural communities as well as in the city. So lockdown isn't quite so straightforward and so simple, but there is talk about London being locked down because people are not taking the social distancing and social isolation messages seriously enough. So we wait to see whether that will actually come to pass, but I'm sure we'll be looking to you to understand how the logistics of that work. I think we should congratulate Wuhan on the decreased cases, the fact that there are now across China very few domestic cases. So that's optimistic for the rest of us when we see that, because we know we're on the upward trajectory of the curve at the current time. But we recognize that imported cases also pose a threat now, today, or just recently. I wondered what the measures that were being taken, because I know in Hong Kong, because I was working at Tsinghua Daxue at Chinese University of Hong Kong for many years. And I know from my friends in Hong Kong that they've now stopped tourists going into Hong Kong. Today, there's been a ban on tourists to stop the importation of cases. Is the same happening in China at the moment?
There are a certain amount of measures have been taken to confront the threat put by imported cases in China. I believe the flights or the seats coming from abroad, especially those places with epidemics, have been cut down a little bit, just to decrease the number of international passengers. Secondly, they have augmented the test capacity for those patients, for those passengers, especially from those places with epidemics. Thirdly, I believe most of them, or a very large amount of them, especially from Europe or the United States, will be isolated for 14 days. They will be isolated in the hotel rooms with enough supply to support themselves. And
I have a question about the emerging effects, the emerging treatments. There's been a lot of debate in the U.S. about whether or not there's sufficient evidence for both remdesivir and for chloroquine. So I was wondering if you would discuss what evidence you see to use both treatments, and also given the limited quantities of both treatments, how should we give it to patients? For example, should we give it to patients only once they're severely ill and on ventilators, or can we give it earlier when they're just starting to see the decline in the oxygen saturation?
I'll say something first. By our experience, actually, this disease is quite hard to treat, just because we are in charge of the ICU ward here in Wuhan. We have a lot of people, a lot of patients who are really critically ill and were on ventilation machines. The mortality is relatively high, more than 50%, we have to admit. Generally, there is a lack of effective measures to save their lives, despite a standardized bundle of ICU treatments. Some people can recover, but a lot of patients, we have lost a lot of patients. However, on the light end, on the mild disease end, we are not in charge of the but we have some information given by our colleagues outside our hospital. The prognosis are generally okay for those patients. Most of them will recover. Some of them will turn into severe disease or critical disease, but the ratio, we believe, is not that high. In terms of treatment, we've talked about the ICU patients. Well, for the mild disease patients, it's generally a self-limiting disease. There are clinical trials in terms of antiviral drugs. Also, they empirically used ostamivir and other antiviral stuff. But generally, we believe they did not make a very big difference due to the self-limiting nature of this disease in mild forms. Any information from Dr. Hall?
Are you mentioning the drug of hydroxychloroquine?
Yes.
Yeah. And the other drug you mentioned it was?
Chloroquine.
Remdesivir.
Oh,
The
remdesivir.
antibody.
Okay. So actually, Dr. Fan has already introduced what we have done in clinical practice. And I just want to add a few sentences because a recent published article from France, the newly published one, testing the chloroquine in treating mild phase patients. Actually, there is a similar clinical trial, which was published around early March, which was done in China, that testing only chloroquine, not combined with azithromycin. But the results of the two studies were not very consistent. In the Chinese trial, the trial showed that the team using the chloroquinones are not, compared with those with controls, have no obvious differences in the symptoms, subsides, or other measures, other indicators. But in the studies from France, there seems to be a significant improvement for those using this drug. So, but for both trials, the sample number is not very huge, only tens of cases. From our experience in clinical practice, those drugs, if can have any efficacy, might only be used at the initial phase of this disease. At the end or late stage, most of the injuries are actually caused by the other mechanism, including the inflammatory syndromes, other mechanism that causing multi-organ injuries. So at that time, those injuries are not directly caused by the virus, though the effect of the virus cannot be fully ruled out. So at the late or critically ill patients, the results of the treatment actually depends on what kind of comprehensive treatment you are using. And for remdesivir, we are still in the clinical trial to show if it will have efficacy for those patients. We have 2 registered clinical trials, one for mild phase 1 patients and the other for critically ill patients. And the initial results are anticipated in about April, I think. At that time, we may have more information to evaluating these drugs.
And how much permanent lung damage are you seeing? I saw one study that showed that about 20% of patients had about a 20 or 30% reduction in lung function, such that they would get out of breath and walking at a fast pace.
This is a good question. We haven't got very authentic data concerning the ratio of frequency of different symptoms, including short of breath. Just because, as a pulmonologist, the symptoms of respiratory system can be variable due to different persons. Another indicator which can be used here is the presentation on CT. Generally, the majority of patients with positive PCR test have some abnormality on CT. Some of them, especially the mild form, can resolve in a certain period of time, let's say 1 month. But some of them, maybe they can recover, but they have scars or reticulation left. And, in critical ill patients, the lung damage is very severe. And there are scars left on the lung due to CT scanning. Another data we can quote here is published by the World Health Organization. They say the severe form of COVID-19, the ratio is about 13% to 15%. Well, by their definition, severe cases are people with hypoxemia and also CT abnormality. Maybe around 15% of people will experience certain amount of short of breath or objective damage of oxygenation, of hypoxemia. This should be a good estimation about the ratio of people.
Okay, before we move on, Dr. Fan and Dr. Cao, let's answer one question from our Facebook viewer.
Okay.
The question is, can the virus really survive in the hot region? Can they?
In a hot region?
In a hot region.
For example, like what?
Like Africa or like during summertime, are they able to survive?
I think they can survive because we can also see cases from different regions of the world. Actually, the climate or the temperature, if they will they have a big impact on the virus? There has been no data regarding COVID-19, the coronavirus. And for SARS, we all know it started from the relatively hot region from Guangdong province. So there's no doubt that this virus can survive there. But we need more data or specific data to see the incidences of different regions to decide if there is true impact of the region or temperature to on this virus.
Yeah, I totally agree. We are not able to account on the temperature to solve this problem.
Yeah.
Okay. Thank you.
Could I ask you just another question? I'm a public health physician, so I ask from a more public health perspective. In China, everybody wears masks, but in Europe and in the UK, we are not advising people to wear masks unless they're in contact with patients. Could you just explore that a little bit?
And I actually want to see your viewpoints about the wearing of masks.
Oh, do you? Okay.
That's a good one.
Well,
I like
I think the position that we've been taking is that the evidence doesn't show that universal wearing of masks at all points is necessarily a safety procedure, doesn't protect people. And it's I know there's a cultural difference here. When I was living in Hong Kong, people would wear masks. Not at time of epidemic, but people would wear masks if they had a respiratory tract infection themselves to protect other people. And as we would want people who have COVID-19 to be at home, we would not be necessarily wanting people out wearing masks. I think the thinking is that masks can protect carers when they're giving care to people who are sick and people who are at risk of being sick. But in general, you touch your mask a lot. You take your mask off when you eat. You breathe into the mask, it gets soggy. You know, all of those issues mean that, in fact, they're not necessarily the protection. And we've been focusing much more on hand washing, not touching face and eyes, and cleaning surfaces around us, and tissue hygiene. That's been the thrust of the message, the containment message in the UK. And we don't tend to wear masks, and we save them for when people are actually infected, and for protection both of healthcare workers and carers.
And I have a follow-up.
That's been the same as what the CDC in the U.S. has been saying. And I think much of that also is driven by the acute shortage of masks and other protective equipment in the U.S. However, I think as we're seeing the continued spread and as masks become more available, it might start to make sense in the U.S. and Europe for people to start wearing masks, especially as we find more and more information on the number of asymptomatic people. Because if everybody wore a mask, the asymptomatic people would not be spreading the coronavirus as much as they are now. So once again, I think that the current recommendations in the U.S. are really mainly due to the shortage of masks. And also there's another theoretical concern that if a non-trained person is wearing a mask, they're going to touch their face more often to adjust it and might be at higher risk of infection. However, I think that's mainly theoretical. And I do see in the U.S., as masks become more available, people will start buying their own and using their own. And you'll see a cultural shift in the U.S. and Europe.
Well, I have a follow-up question for Professor Sean, that UK Scientific Advisory Group for Emergency said social distancing needs to be in place for most of the year to be effective against the virus. So what's your take on that?
Well, all the advice in the UK has been very heavily predicated by the advice to the politicians has come from SAGE, as you say, that group, and people like Neil Ferguson, Professor Neil Ferguson at Imperial College and his team, and other teams who've been doing the modelling, suggest that social isolation and social distancing will depress the curve, hopefully, of the epidemic, but they will extend the curve of the epidemic. And the big fear is that there will be a second spike come November time. And so to prevent that, the theoretical position is a year to 18 months. I'm not sure how that will be implemented. And I think if we look at Wuhan, it wasn't 18 months, it was 3 months, wasn't it? And it's just the tolerance of the population, because at the moment, the social distancing, the people over 70 are basically asked not to mix at all. The very vulnerable, the people who are immunosuppressed, are from today going to be receiving food packages and not expected to go out. Okay. So we've started to ramp up the social response. Children are no longer in schools. We have all the children are now not in school for the foreseeable future, just as you've been through in parts of China, not the whole of China, I know, but we are now getting into that situation, and whether that's sustainable, whether the social side of that is sustainable, and the economic side, because it's hitting the economics really hard, particularly self-employed people, low-wage people, people in the hospitality and the industry. All these people are no longer earning, and the government's had to come and come up with a package where 80% of people will be getting. You'll be getting 80% of your pay as long as you're employed. All these social measures are now coming into the UK. So how long are they sustainable is really questionable, which is why everyone is really being urged to take this disease very seriously, because everybody's lives has changed in the UK. It is just totally different nowadays, really very different than it has been. But there's still people ignoring the warnings. Yeah. So it's, it could be, the question is, how long is it socially sustainable? How long can you stop grandparents seeing their grandchildren, for example? How long can people stay out of work? What will they do if they have to stay home and they have no income? There's a whole social set of questions there about the modelling. The theoretical modelling is fine. Mm-hmm. How does it then apply to society? And that's the decision the politicians have to make. Yes. I don't think the states are there yet, are they, Kate?
Well, actually, 25% of the U.S. is on lockdown now, so mainly hitting the larger cities and more metropolitan states, and I see a lot of other states, moving towards that in the near future. And so there is this big question of public mental health and how do you keep people mentally healthy when they're at home. And certainly the recommendations like keep a schedule, reach out via video conference to friends and family, reach out to your religious community. Learn a new skill, do exercise in home, keep a journal, talk to people about how you're feeling and express it. But this, unfortunately, is a huge natural experiment in public mental health, and I think we'll see high rates of anxiety and high rates of depression. I know that my colleagues in psychiatry are already seeing upticks in the degree of mental illness in people who already have psychiatric diagnoses, like people with depression or with schizophrenia, starting to experience worsening symptoms.
Well, another comment on the mask is we believe surgical masks for the people to wear is a kind of tool to reduce their anxiety during this time. They wear a mask, they feel safer. The mental anxiety has been kind of reduced. But N95
I'm really glad you mentioned that, because that's been a huge issue in U.S. hospitals, with administrators actually taking off the masks that health workers have brought in from home and really not understanding that suiting up in your personal protective equipment for a health worker is like a knight putting on his armor, and it has a huge psychological component. And luckily, there are some bright spots in the U.S. that communities are starting to sew masks and other protective equipment for the health workers. So the health workers will now be able to physically put on a sign of the support of the community. And that, I think, will have a great boost to morale. But administrators need to understand that health workers are under extreme pressure now.
Yes.
And let someone wear a mask if that's what they want to do. It'll make a big difference in their morale.
Yeah.
Well, by our experience, the transmission capacity of this virus is very horrible. You easily get it if you do not wear a mask. We have a case which has been reported by the television. One guy went to the market to buy something, and another later diagnosed patient passed through. They came across like for 10 seconds. The second patient only have these 10 seconds of contact, and he got the disease. It's worrisome.
Yeah. You know, on the issue of health workers, what measures have you found were best to support health workers and keep them resilient and keep them?
最后一半啥？
Providing them food, safe, clean places to sleep, mental health hotlines.
Yeah, we have all of those measures to keep the health workers find themselves comfortable. First, you have a reasonable schedule for all the medical workers, no matter the doctors or nurses. They need enough rest besides the time of work, which will make themselves relax. And good food, and also communications with each other. We have also medical workers who have survived or participated in the 2003 SARS epidemics. So then actually our team is mixed up with the older generation and the younger nurses. And those experiences from those old workers will definitely be a support for these younger medical workers. And also the local hospitals also provided a psychiatric hotline for us for interviews, like if you have problems with sleeping or feelings, you can have an interview with them. And also to give the medical workers enough knowledge about how to protect themselves and demonstrate that under this protection they will be safe, will be a great help for them to overcome their fear or scare for this disease.
So far we've got 0 infection in our team, medical workers.
Yeah.
Really
in those who have come outside from Hubei province.
Yeah, furthermore, the enough resources such as face masks and N95, personal protecting equipment is also important. You don't want them to go to the battlefield without armor, without cannon, without rifle. That's unreasonable. No one will survive this war without enough resources.
Can I ask you what the current thinking is about children and the disease? Because the initial report from Wuhan was that, interpreted anyway, was that children didn't get the virus. But I think nowadays we think more children are getting the virus, but it's still not as severe. What's your current thinking on that?
The data, the already published data or reported data is that children are also vulnerable, but probably because of the opportunities of their touching outside people or communicating with other people except for their family members. So children are actually having much lower opportunities to getting viruses from strangers or social communications. And reported from those already being diagnosed, most of the children are above 1 year old, and there are also reports of children, of infants. However, we don't know what's the reason. The results of these outcomes of these children are generally good. Currently, no one has been reported died, I think.
No one.
All of them have been cured. We don't know what's the reason that they have such good prognosis, but the situation is that children are vulnerable, but their outcome seems to be better than what we saw in adults.
Yeah, well, we have to say the whole population, from infants to the elderly, are susceptible to this disease. But generally, we're concerned more about the part of the population, let's say more than 60 years old. In the ICU setting, we experienced the death are almost all above 60 years old patients. So there are more to be worried about than the infants and kids.
Kate, please.
With your surge staffing, you brought in 40,000 health workers from outside of Wuhan. How did you arrange your teams? Like, what was the team makeup, especially since you probably were having a lot of physicians and nurses working in the ICU for the first time in many years. So I imagine you might have to create job aids, create different types of teams. How did you do that?
Well, let's take our team, for example. We are from Peking Uni Medical College Hospital. We have like 4,000 staff in total, and here we have about 190. Among them, about 40 to 45 persons are doctors, including director, supervisor, first-line doctors work as residents, also second-line doctors working as attending physician, and the rest of them are all nurses. Just because we are in the ICU setting, nurses are share a very large quantity of care burden than the doctors. I believe in other medical teams all over the nation, the composition can be variable, but generally doctors and nurses share the working load. Maybe nurses will be more than doctors, but they are all inside the same team, generally working together and working cooperatively.
Yeah, at the first few days of February, medical teams from different hospitals or even different provinces have to work together in the same ward. And afterwards, when more and more medical workers come into the Hubei province, basically people from the same hospital will work at a single ward to care the patients of the ward. And medical teams are assigned. There is a central office in Wuhan to direct or assign the medical teams where you should go and in which settings you're working. So we have actually medical teams in ICU settings, also in ordinary wards, also in the emergently set up big hospitals for those who are mild or asymptomatic cases. I think actually this is a question maybe for higher levels, but just the example of how our team worked here. Yeah.
And there were training sessions for those non-ICU medics, right?
Yeah.
At the same time here at the hotel.
Yeah, and the resources are allocated and coordinated by the government offices. They discuss, organize regular meetings to see whether this one should be strengthened, or that one can be kind of released. So it's a dynamic process. It's not always fixed.
Yeah, okay. Another question from Facebook viewers. Okay, this is the question that everybody wants to know. Do we already have the coronavirus vaccine?
No, not yet.
Not as we know. Not as we know. There are 2 trials. The United States have pushed the trial. The first dose has been implemented, and also in domestic level, by the military, there is a product which has been entered the trial time. Well, actually, experts from all over the world have told the public that the innovation and implementation of effective vaccine needs about 1.5 years. So we believe that that's the law of nature. So we just look forward to effective vaccine to come out, but not as we know. This is already in use.
It takes years.
So in the U.S., a vaccine trial started a week ago Monday with the first people receiving the vaccine, and the FDA has already been asked to make the regulations less strict so that the results can come out faster and that perhaps healthcare workers or high-risk individuals could receive the vaccine faster. So as you mentioned, instead of taking a year or more, perhaps the vaccine could be out to select groups of people in 6 months.
Okay, good to know.
Okay. Professor Sean, any questions from you?
We had a discussion in the UK, you probably heard it, about herd immunity. And that it was. I think it was a poor way of expressing the fact that we're trying to suppress the demand curve. But I just wondered if you'd had any discussions about the need to increase herd immunity, as we haven't yet got the vaccine.
Well,
I know it's a difficult one because I know that the idea that was expressed in the UK at the time was that actually, given
that's the
that
reason why
80%
people
of people
say
get
that's
the
a
disease
very,
and
very
don't have too many
rational.
problems, would it really be such a bad thing if it was spread amongst a younger community?
Yeah.
That was not acceptable socially. There was a huge reaction to that, and then but it was part of the thinking in terms of where we got to in our social distancing, social isolation policy, and our sort of potential further lockdown moves. So it was just a part of the process, and I don't know whether there had been any discussion when UK suggested it, or whether you'd had any discussions about why herd immunity might help protect the population in the future.
Well, I'm not a public health major. Our public health training is very limited, frankly speaking. Well, the herd immunity to me is more reasonable if there is a vaccine or the disease can be vaccine, such as H1N1. As a pulmonologist, I took a flu vaccination every year. In terms of such diseases with effective vaccine, the herd immunity is more reasonable. Well, we had a lot of reaction to this to this talk here in China too. But to us, it sounds like okay, we will passively let more people get the disease and protect the rest. Well, we have seen a lot of patients, especially in the ICU end. Well, the disease is very cruel, very severe, and the damage brought to the family and the patient, even if he or she recovered, is very huge. And also, I have to say, my parents are in the high-risk group of people for this disease. So to me, let the whole country, so large a population to experience the disease and get immunized passively is not acceptable to me as a citizen, as a son, and as a doctor. That's my personal opinion.
I must say that I think that what happened was it was poorly expressed. We have daily briefings, and I think it was a poorly expressed idea, because the idea was really to make sure that the health service could cope as well as possible. So it was how to maximize the National Health Service so that everybody could get the care they needed when they needed it. And the idea was that more people stayed in the community with the disease. But we have actually, it was then made very clear that it was not the policy. Promoting herd immunity is not the policy in the UK, but I know that it was interpreted for a while as that was the policy. So it's probably worth making absolutely clear that isn't the policy. Although obviously over time, higher herd immunity would help protect people, and the vaccine is one way. I also wondered whether we've been talking about testing a lot, and there's been a problem in getting the right number of tests, but also the development of an antibody test as opposed to the antigen test. Who has had the disease? How far has that got in China?
We now have the kits for antibody tests in clinical settings, and they can be a good information provided besides the test of virus. And besides this, because of there are different problems associated with virus testing, the PCR methods, and also the accuracy of sampling when you try to test the patients. So the antibody test will be a good supplement for this virus testing. Also, it can be used for the afterwards testing of the whole population to have a general idea of how many patients have actually been infected, and to have a more accurate number of those for those rates and incidences. Yeah.
You haven't got the test yet, though, for the population?
Not in the large part in China, but I'm sure they have already done a epidemiologic survey. I heard that's in Guangdong province or some areas in China. Yeah, and I'm sure after we have already ended this battle, we will gradually go into the next step to have a general idea of the whole population.
I have a clinical question about the management of patients in ICU. So we've heard that it might be better to keep the patients not over giving them too much IV fluids and not overfeeding them. What have you found as far as outcomes and IV fluid resuscitation and feeding?
The simpler way, first of all, I have to emphasize again, the mortality rate of ICU patients, especially in those who were intubated, is very poor. So I believe the medical team all over the world should be well prepared for that result. A lot of patients are going to be lost. Secondly, we can understand the whole pathophysiological process and the pathology and the clinical management of these patients due to ARDS, acute respiratory distress syndrome. We have done some autopsy study, and the pathological results, especially in the lung part, is very accordant to ARDS. Generally, in ARDS patients, we apply several strategies together. The first one is restriction on fluids. You don't want to give them too much IV fluids in the form of natural saline or other things, unless they have signs for septic shock. Secondly, you have to use low tide volume strategy when doing mechanical ventilation. And thirdly, if the mechanical ventilation is hard to manage, you will use prone. We have seen a clip of video which were photographed in Italy. A lot of patients on their side was on the prone position. And finally, in some selected patients, we use ECMO sometimes, but generally the results, especially in those ECMO patients, are really poor. To my understanding as a pulmonology and critical care practitioner, I believe the principles and the strategies which were applied to ARDS patients for a long time can be directly used here, including IV restriction.
Okay. Do you have any questions for Kate and Sean?
Yeah, I do have some questions. Well, the first one is I've talked to friends and colleagues who work in the United States. Yes, they are having a very hard time just because short of personal protection equipment. My first question is the N95 really that hard to obtain right now? Or are there any measures taken to solve this? Secondly, is the situation changed that medical staff are not encouraged or even allowed to wear masks during this epidemic?
So yes, masks, whether surgical masks or N95 masks, are in very short supply. Back actually in January, I went to 3 local drugstores and tried to get a surgical mask, and there were none. They were all sold out. So really for the last 2 or 3 months in the U.S., there's been a run on masks. So they're just not available. And unfortunately, the masks that are in the strategic stockpile are now just being released. So this is about 2 or 3 weeks too late. And we hear lots of reports, unfortunately, of hospitals around the U.S. where administrators are forbidding healthcare workers from wearing masks. And it's hard to know how to manage this situation, because health workers, especially physicians, aren't represented by unions. And so it's hard for them to speak with one voice and push back against some of these rules, which don't make sense. Okay. And as far as the availability, soon 3M, which is a major company that makes masks, it is really ramping up its production in its U.S. facilities. And so hopefully in the next week or 2, more will be available. And also, as I mentioned before, local communities are sewing cloth masks up for their healthcare workers.
Okay. I have 2 more questions for both Sean and Kate. As we know that we have seen an increasing number of deaths and confirmed cases in the U.S., and also the World Health Organization has seen Europe as the new epicenter of the pandemic. So what should be the next step in coping with the new virus in Europe and in the U.S.?
Sean, please, you're first. Well, I think the difficulty in Europe, Europe is a collection of different countries, and so each government in Europe will be making different decisions based on its population. So we've all been looking at Italy, where that's the epicenter for Europe. And the estimate is that we're a couple of weeks behind, which is why I think you've seen an increasing emphasis on social measures, the increasing lockdown. And I think that's what we're beginning to see, increasing lockdown in most of European countries. Travel is severely restricted, people are being asked to stay at home, schools and universities closed, and everyone asked to make as much effort as they can. I fear that should hopefully, I keep saying to people, this too will pass. I remember SARS in Hong Kong and the feeling of as the cases were increasing and how you felt so hopeless at that point when cases were increasing. As they start to turn, things become more optimistic, as you found in Wuhan, as Korea had found until it began to get imported cases. So we need to be very careful to avoid re-importation of cases once we're on top of the disease in Europe. I fear for other countries with less strong healthcare systems. I think European healthcare systems are fairly robust. I think in sub-Saharan Africa the threat is way greater. And I think we should all be thinking globally, not just thinking locally. And what do we do together globally to mitigate against this disease? So that's our next big challenge, I think.
Yes, in the U.S., you'll see increasing lockdowns and increasing social distance. They're already starting to build the auxiliary emergency hospitals now. And as I was discussing before, also seeing how much they can shift to community-based care, that people who are just requiring medical oxygen might be at home or in a community center. But as Sean said, there really needs to be a push for a vaccine and other treatments. And I've been very encouraged by the degree of data sharing amongst healthcare workers. The fact that the Chinese team shared the gene sequence has made a huge difference. And we need to keep this up, keep sharing what works, what doesn't work, combine the data so we can find out what therapeutics work. And also I share Sean's concern about some of the low and middle income countries, particularly in Africa. I think unfortunately there was a false sense of security that their hot climates, the virus wouldn't transmit very well. But even if they have an outbreak 1/10 of what you see in Italy, their health systems will be overwhelmed.
Yeah.
So I'm very concerned about that. And it's hard to know how we can help because we're not in a position right now to send healthcare workers because they're needed at home and there are all the travel restrictions. So at least we can share the data and share the best practices. I know my team is working on a surge staffing plan for a country in Africa. We just need to share all that as much as we can.
Yeah.
Yes.
Okay, thank you very much for your insights. Because of the time limit, we have to put an end to today's seminar. Hope it's been quite fruitful for you. I think since the situation worldwide is not quite promising, so I think meetings like this are very necessary to help exchange views and help with the epidemic control and prevention. Thank you very much for your participation, Sean and
Thank you.
Kate.
Thank you.
very much.
Thank you.
Thank
you.
you. So
Thank you
stay
for your
tuned
advice.
and we'll see you next time. Bye for now. Bye.
Bye-bye.
Bye.
Bye-bye.